For years, primary care has been at the heart of quality improvement. But with so much changing in healthcare, how should primary care evolve? I'm Andy Reynolds. I spoke to two primary care experts about their news and predictions on how primary care can drive quality improvement in 2026 and beyond. Please say who you are and what you do.
Hi, Andy. I'm Karen Johnson. I am the Vice President for Practice Advancement at the American Academy of Family Physicians, otherwise known as AAFP or AAFP. That's all us, representing 130,000 family physicians and medical students. The work we do ranges from helping students understand what family medicine is all about and anything related to their journey as a family physician, having a successful and satisfying career.
Thanks, Karen, and welcome. Turning now to my NCQA colleague, Jeff. Please tell us who you are and what you do.
I'm Jeff Sitko, Assistant Vice President of Product Management at NCQA. My role is to oversee the care delivery side of our program portfolio.
Karen, you mentioned helping people have a successful and satisfying career in family medicine. So let's start there. What do most people not know, or what do they misunderstand about what it takes to have a successful and satisfying career in primary care?
One of the things that's changed a lot over the last 20, 30, 40 years is the corporatization of healthcare. I'm old enough to have grown up in the Marcus Welby era. That's the family doctor, the guy with the medical bag who would even come to your home back in the day. But many of us grew up also just going to Dr. Smith's office or Dr. Johnson's office and working directly with physicians. Now you're going to buildings with names on them, corporate names, as opposed to doctors Hauhoko and Garcia, who I went to when I was a kid. Out of that 130,000 I mentioned, about 75,000 are practicing physicians doing clinical care. About 70% of those are employed. So there's a diminishing number, a really important number that continue to practice independently, physician-owned and led practice. But it's that relationship people are looking for with their primary care physician. For most physicians, the relationship with their patients is most valuable to them. That's just one of the things that I think people don't always appreciate. They think about sort of like, well, what tests and procedures are you going to do? But for primary care, it's much more about the relationship. And so what's changed and what people ought to know is that's still the core of what primary care is. That's relationship, and the continuity of that relationship is what makes primary care special.
Many guests on our podcast say that fragmentation is the number one problem in healthcare today. What's your view of fragmentation?
Yeah, so much to say about that because there's fragmentation of data, and that's representative of how complex a patient journey is across the healthcare ecosystem. We go to different places to get our care, even if we're really not sick. And we have a primary care physician as our predominant source of care. And so it's funny, I talked about relationship and now I'm talking about data, and they seem like opposite ends of the spectrum. But if a family physician or primary care physician doesn't have complete information on you as a patient when you walk into their office, they're not going to be able to provide the best advice, best care, best direction. You're going to spend a lot of time mapping together what happened instead of talking about where you go from here. The National Academies of Science, Engineering, and Medicine put out a report almost 5 years ago on implementing high-quality primary care, rebuilding the foundation, that in recognition that primary care is the foundation of a high-performing healthcare system and that everyone needs high-quality primary care. Not everyone needs high-quality cardiology, oncology, or neurology. We don't all need those things, but we do all need high-quality primary care. So when we think about fragmentation, we have to think about primary care differently. It's not one of the specialties that's important to the healthcare ecosystem. It is the foundation for everyone. All of the other specialties are important, and we need good relationships and good sharing of information, but it's different with primary care.
Can I add to that point, Andy, if that's okay? I would completely stack hands with Karen on the reach of primary care. Primary care, Karen put it well, it's the foundation of any high-functioning health system. When you have the general population as your focus, By definition, you have an opportunity to make an impact, how you can impact quality, how you can impact total cost of care. It is in the primary care space. You touch the most lives. And when we're talking about especially primary care as prevention, that opportunity in primary care is huge.
We'll come back to preventive care. First, can you update our audience on the status of the Patient Centered Medical Home, or PCMH, please? That is a way of organizing primary care that took off 15 to 20 years ago. The NCQA website shows that over 30,000 clinicians work at more than 6,000 recognized patient-centered medical homes. Can you fill us in on how PCMH fits with what we're talking about today?
The patient-centered medical home model is foundational to high quality, high functioning primary care. It's been a minute though, like you said, Andy, since the patient-centered medical home model came onto the scene. We've had the patient-centered medical home model here at NCQA since 2008. We're 17 years out from that. The patient-centered medical home model is essential anatomy for high functioning primary care. But now it's a question of physiology. How are you taking that anatomy, that essential structure, and putting it into action? That's where I see the next step after the patient-centered medical home model, looking at the output of that structure. Let's talk about outcomes. Let's talk about the performance, and then what is the impact to patients?
If principles of the patient-centered medical home are the foundation of good primary care, what are the challenges or forces pushing against that foundation?
HRSA has predicted that we should expect a shortage of PCPs by around 2037 in the range of about 87,000. That's a significant shortfall for where we would need to be to support better outcomes for patients.
Okay, so strains and shortages in the workforce. Karen, what's your take on the primary care workforce?
We can't have a conversation about primary care today without talking about the workforce that is under so much stress. The study published in the Journal for General Internal Medicine this year, called The Pulse of Primary Care, talked to primary care clinicians about the state of primary care. More than 60% said it's crumbling. But when they were asked what allows them to thrive, about the same number said it's relationships with their patients. That's the thing that allows them to stay engaged. So building a system that allows those relationships to thrive is essential if we're going to have a primary care system in the United States. We see up close and personal the toll that working environments that aren't changing quickly enough for many physicians and other clinicians, the workforce is so challenged. How do we preserve and protect the workforce we have while also inviting a new generation into this work? We've got to make it a satisfying and valued career, whether it's physicians or nurses or health techs or support folks. I'm worried about the workforce in primary care, from physicians to the front desk, and making sure the work is attractive to those that we want to bring into the workforce and satisfying to keep those that we have.
We will link in the show notes to those reports that each of you cited. But how exactly can we make working in primary care less burdensome and more attractive?
I'm most excited about technology that is coming to the fore for primary care. I know it's the sexy expectation to talk about AI on every podcast or every conference, but there's such tremendous potential there. Expect that convenience component to be vital. Look at the potential. Not just do we have electronic charts, but now we're talking about different modalities for visits, virtual visits. We see what AI can do to cut through the noise from an administrative standpoint, navigating workflows, recommending resources for patients. It's a huge chance for us to infuse more joy in work for clinical professionals that got into this business to take care of patients, not just to click the right boxes in the electronic health record. There are so many opportunities for us to have a brighter future in primary care based upon the tools available today that allow for them to focus on where they need and want to direct their attention. There's an ocean of potential. I'm deeply excited about that.
Karen, what's your take? Can technology make working in primary care more livable?
I am excited about the opportunity that technology brings. And I'm going to echo what Jeff said about AI in particular, the ability for it to address the administrative tasks that bog physicians down and keep them from being physicians. If we can automate those tasks and free teams to focus on patients, it will get us back to the kind of primary care that we all want and need. We can do primary care a lot of different ways. Here we are having this conversation through a computer that 20 years ago we would have never imagined conducting business in this way. Getting the care you want, the care you need, when you need it, in a way that's accessible to you are certainly something that should be available. That speaks to importance for patients, but it's also important for clinicians. They want the same flexibility, of course. It should be convenient. It should be convenient for patients, and it should also work for those who are delivering the care.
Okay, but if the biggest shortage is people, shouldn't higher pay help attract more people into primary care? Or how should we think about the economics of labor in primary care?
Less than 5% of total healthcare expenditure is on primary care. That's not where we're putting the money.
I'm glad you mentioned the percentage of spending that goes to primary care because that tells a big story. Primary care shouldn't necessarily be expensive. It should be available and accessible to everyone. But there was a paper published this year, and they asked folks, how much do you think we spend on primary care? And the answer was 50%. The majority of us who aren't in need of expensive things that happen to people who are very sick, most of us spend most of our time in primary care. So they thought 50% probably was going to primary care, and they thought 60% should be going to primary care. Both are obviously different than the reality of 5% of spending. That spoke volumes in terms of the appreciation most of us have for primary care, but it also said a lot about how much more complex the system is than what we understand. And sort of maybe some of the incentives we built into our healthcare system are not necessarily pointed in the right direction.
Karen, I'd like to make sure I'm following the math. People think that the primary care spend is 50%, but you have to knock a zero off of that to get the real number, 5. So
Yes.
people are wrong by a factor of 10.
Yes, that is correct.
Wow, that's quite a misperception.
What you don't spend on primary care are dollars being spent on other things that we're spending a lot of money on. Then the thing we probably don't talk enough about is, are the things we're spending a lot of money on really worth the money? And I'm not saying people's lives. I'm talking about the cost of the technology or the cost of the pill or the cost of the procedure.
NCQA's founding president, Peggy O'Kane, who retired at the end of 2025, said many times that if you don't pay primary care doctors appropriately, the work of quality improvement cannot be done. Karen, is there anything else you'd like to say about paying primary care clinicians?
Yeah, it's essential for the work to retain and attract the workforce we need. And I would go beyond just paying providers, but resourcing primary care practices. So I agree with Peggy, but I would just frame it's not just what physicians are paid, but how we support the primary care system because it takes that whole village to deliver high quality primary care. And we've got to make that the priority. Patients told us they wanted it to be when they told us in that study we should be spending 60% of our healthcare dollars on primary care. So maybe it's not 60%, but it's certainly not 5%. There's a number in between there that we ought to be striving for.
Jeff, I feel like economic constraints and misaligned incentives have dogged primary care for a long time. Are there changes there that give you hope?
We have some good progress. We have the advanced primary care management codes that are in the Medicare physician fee schedule now. We're not talking about services that are time bound. We're talking about how it actually is driving that relationship, how it is coordinating better care. That is a big win. The new access model out of CMMI that's talking about 4 different clinical tracks and conditions that we can incentivize providers on, that's huge. So we're seeing some good steps in the right direction.
Karen, what shifts in the economics of primary care have caught your eye?
We're seeing states prioritize primary care. They're passing legislation to increase spending on primary care. Some are exploring ways to fund primary care as a common good at the state level. At the federal level, this administration has been clear about its support for primary care, and not just primary care, but independent practice primary care, something that should be physician led. And it certainly takes a team to deliver the care, but you need physician leadership in the business model to make it work, and the accompanying payment mechanisms to do that, not as an innovation model exclusively, but in the permanent sort of Medicare program, the Medicare physician fee schedule, the advanced primary care management codes. Not perfect, but certainly a big step in the right direction. We are heartened by those things we see happening.
How else might the future of primary care be different than what we know today?
We're looking at healthcare as more data-driven that enables primary care to be proactive rather than reactive. And also primary care is a space where we can prevent illness, not just a place where people are having reactive care. That's not good preventive care.
I agree with what Jeff said. If you want to boil it down to the simplest terms, it's taking primary care from a reactive model. Call me when you're sick. I'll put you on my schedule. Come in and see me, to a proactive model. I am paying attention to a population of patients. They're mine. They're on my panel. And now maybe they're also tied to some accountability arrangement in value-based care where performance comes into play. And so I'm going to be proactive for a lot of reasons. One, it's the right thing to do for patients, but I also want to make sure my patients are getting preventive services they need. They are taking the medications I prescribe. They are going to the referral I recommended, and I'm getting the information back from that physician, and my team is acting on that. It's all of those things that should be ubiquitous in primary care.
Jeff, this podcast episode is NCQA's first of 2026. Many in our audience will be eager to know what they can expect from NCQA in the new year regarding primary care. What can you tell us?
We've had the patient-centered medical home model at NCQA since 2008. Now we're talking about primary care's next stage, supporting practices on the path they're already on, building on the strengths that primary care teams are bringing to their work every day. So the goal is a clear framework that recognizes what's working in primary care. How do we help to reduce friction? And how do we make it easier for practices to deliver the care that they're striving for? We see this as an evolution that honors the realities primary care practitioners face, not adding another layer of burden. So it's more about a support system that meets them and helps them keep moving forward.
And what's your schedule for all that, Jeff? When should people look out for new NCQA standards and evaluation services regarding primary care?
Anticipate hearing a lot from NCQA throughout 2026. We're going to have public comment. In the summertime, we encourage anybody that has a stake in primary care and has a sense of where they think we should be headed to provide input into the standards, into the measures we're trying to build. And then from there, anticipate the broader launch of advanced primary care, as we're calling it now, in November 2026.
Karen, looking ahead to 2026 or beyond, what are you most curious about, or what are you most eager to learn about primary care?
The thing I am most curious about is what's going to be the seismic shift that's going to help us see primary care as a common good, as the foundation of a high-performing healthcare system, and resource it for that to happen. That means changing financial incentives. That means addressing data interoperability issues. It means doing a lot of things we haven't had the will to do in a meaningful way. And we need that seismic shift. So I wonder who's going to create it. Is it going to be at the federal level? Is it going to be at the state level? Is it going to be in the private sector? We need all of those actors to move in the same direction, but we've got to have a first mover. I'm excited to see who it's going to be. I'm curious to see who it's going to be.
I think that's a good place to end. Our guests today have been Karen Johnson, who is Vice President of Practice Advancement at the American Academy of Family Physicians, and Jeff Sitko, who is Assistant Vice President in Product Development at NCQA. Karen, Jeff, thank you for joining us on Quality Matters.
Thank you,
It's
Andy.
been great to be with both of you. Thank you so much.
Thanks, Karen.
Thank you for listening to Quality Matters. You can always learn more at ncqa.org, and be sure to subscribe to Quality Matters wherever you get your podcasts.